Good evening, everyone, and thank you for joining us for tonight's clinical webcast, Improving Orthokerotology with Corneal Topography, brought to you by OCULUS. The first thing I'd like to point out is that you have a questions text box on your GoToWebinar control panel. I encourage you to type in your questions during or immediately after the webcast, and we will have time for a Q&A session after the presentation. Our speaker this evening is Dr. Jason Jedlicka. Dr. Jedlicka is a clinical associate professor at Indiana University's School of Optometry and chief of the school's cornea and contact lens service. He's a fellow of the American Academy of Optometry, the Scleral Lens Education Society, and the Contact Lens Society of America. Dr. Jedlicka has lectured internationally and written many books and book chapters on contact lenses and anterior segment disease. He is a consultant in the contact lens industry, conducts clinical research for several contact lens manufacturers, and is also co-designer of one of the leading scleral contact lenses. On behalf of Oculus, I would like to thank Dr. Jedlicka for being here to share his experience and knowledge. And again, I'd like to thank everyone in attendance for being here. So now, without further delay, I would like to welcome Dr. Jason Jedlicka.
Thank you, Chris. It's a pleasure to be here tonight, and I'm thankful for each of you who is taking time out of your evening to spend this time with us tonight as well. So we'll spend a little time tonight talking about corneal topography and orthokerotology in particular. I've had the opportunity to have a keratograph corneal topographer for going on, I guess, 7 years now, and I really enjoy the instrument. We use it a lot. We use it every day, multiple times a day in our practice. When I was in private practice and now at Indiana University, we use our topographer a lot. And the keratograph's a workhorse, and it gives us great data for all of our patients, but in particular, I love it for my orthokerotology patients. So talk about that tonight. Again, the keratograph has many uses. It's a versatile instrument, in particular the keratograph 5M, which, as many of you know, has a dry module and lots of other capabilities. With it, we can detect and monitor ocular disease, corneal disease, keratoconus, things like that. We can use our keratograph from an anterior segment disease management perspective. We can also use the imaging aspect. You have a photography option. Again, with the 5M, you can take anterior segment photos, which are great quality. You have lots of different settings for the photos to enhance the image and capture it from different perspectives with infrared or cobalt blue light. And so that's another great aspect of the keratograph. And again, the dry evaluation aspect of it is another bonus that this instrument brings that other topographers just don't have the same capability. But tonight, again, what we'll talk about more specifically is just basic corneal topography, how we use that data for contact lens fitting and follow-up, and in particular, how it pertains to orthokerotology. So when you look at corneal topographers, and I'm excluding the corneal tomographers from this discussion, but we're just talking about corneal topographers. These are Placido disc instruments where we're getting a light reflecting rings off the cornea, and the instrument picks that reflection of rings back up, and then it takes that data and it does calculations to tell us things about the corneal shape and elevation, and some of it is real measurements and some of it is interpreted and calculated measurements. And it's, again, we're talking about a tear layer dependent test. It's got to have a good tear layer. But again, it's telling us a lot about the surface of that eye. There's generally two types of instruments, and this is actually a reasonably significant part of what I wanted to talk about tonight is what's the difference and why would somebody choose a topographer which has the smaller ring or smaller cone compared to the larger cone, which you see on the right, which is what the keratograph employs. And for many years, I used a corneal topographer that had a small cone, and it worked, but and it does capture a lot of data, but it can be intimidating for some patients and difficult to get images at times. As you see from the images here, when we use a small cone topographer, we often have to get in very tight to a patient's eye, sometimes even pressing against the lids or brow, sometimes having to use cotton tip applicator to pull the lids apart to get in close enough and tight enough. And again, for an adult patient, that's not necessarily a problem. On deep set eyes, it can be a problem, but they're usually willing to tolerate working with us on this process. But when we're doing this on children, sometimes it's hard enough to get a topography on a child as it is. But when I have to start pressing my cones in against their brow and getting in very tight, pulling their lids apart with my fingers to get in tight enough to get an image, that doesn't always work so well. And that was actually one of the major reasons 7 years ago that I switched to a keratograph, because I wanted the ability to do corneal topography on my ortho-K patients, most of which, not all, but most of which are children. And I wanted to be able to capture a good topography in a comfortable, simple, easy way that wasn't intimidating to the children that I was taking these maps on. And so that was one of the major reasons for me getting a keratograph to begin with, and I haven't been disappointed. And I'll show you a little bit about just how easy this acquisition process with the keratograph is. Again, you can see here the working distance. The instrument sits back, a few inches away from the eye. There's plenty of room. It's open. It's inviting. It's not a intimidating process. It doesn't touch the lids or brow. And again, sometimes if someone's got a deep set eye using a small cone, you have to tilt the head or twist the head somehow to try to get in tight enough to get the image. You don't really have to worry about that with the keratograph. You're going to get good data on any type of eye shape or brow profile because of the way that the instrument works. Obtaining a map, again, is very simple. It's just so efficient. And I think that's one of the beautiful things, and what I love about it is it's so efficient. We bring a patient to do a keratograph. We can sit down at the chair, and certainly the longest part of obtaining a map is typing in the patient's name and date of birth. Because once we sit them down at the instrument, we enter the patient data screen, we type in name, date of birth, and ID number, and we hit our acquisition button. And what we immediately see is this red ring with these little arrows, and the arrows are directing our focus and our positioning to obtain our map. So again, the instrument is really dictating where to position the ring for acquisition. You don't have to do it. It tells you it to move up, down, left, right, or to twist the joystick to move it in and out of focus. So the acquisition part's very simple. It's very straightforward. There's really very little learning curve. Most of the students at the university, we teach, they do it on one eye once and they're good to go. They don't need any more practice. It's that straightforward. As far as obtaining the measurement itself, again, once you are in focus and you've got the crosshair aligned and all the arrows disappear because you're in focus, the instrument automatically captures a single image, and within about 2 seconds on your screen will pop up the image of your patient's cornea with the Placido disc ring superimposed, just like the image we see here. And then next to it pops up their corneal topography with all of the analytical data about their cornea. It's extremely fast. And so again, from that point, I can glance at the map, I can choose to do another image, swing over to the left eye, and again, within about 5 seconds, I have taken my map and have the data in front of me. So it's not a stretch to say that for a patient perspective, to walk them into the room where the keratograph is and to be walking out with keratometric data and corneal shape and size information, it takes about 1 minute. And again, that's including 20 seconds of that time for typing in the patient's name and date of birth. So it's extremely quick. And this is a video. I hope this will play. Hopefully you can appreciate this. And so we're just pushing the instrument into focus. You'll see the arrows come in, and when we get focused, it just automatically captures. So again, it's a very easy instrument for users, for technicians, for students, for anybody who would be using this instrument. It's extremely simple to use, and again, it's very comfortable for patients. And when we start looking at the differences between the Keratograph and other topographers, you can get into the data you get back. They're all, a lot of these instruments are giving you good data already. What are the other differences in how they acquire? How are they efficient for the office to use? And how easy are they for the staff to learn? And how comfortable are they for the patient to sit through the testing process? And those are the things we maybe don't always look at when we're looking at, what kind of data am I getting from this instrument? The data you get from the Keratograph is excellent, but I think some of the other aspects of how to use it, we don't consider as easily, and there's certainly selling points to me in terms of why I like my Keratograph. So let's talk a little bit about the output that we do get from the instrument when we obtain just corneal topography. Again, we're not going to talk a lot about all the other aspects of the Keratograph, such as the dry module and things like that tonight. But so again, we've acquired a map, and upon the instrument getting perfectly aligned, it immediately captures, and what pops up literally 2 seconds later is what you see on your screen now. So we're going to get immediately a picture of the patient's cornea and the ring superimposed. And why that's helpful is it allows you to immediately look at the quality of your image. And you can immediately see how the Myers look. Is this a good map? Do I need to repeat it because there's broken up Myers? And so then again, as you look at the topography on the right, which in this case is an axial map, one of the options you have, and if you see something about that topography that's concerning, I'm questioning, is this a real finding or is this an artifact? You immediately have your photographic image of the Myers right next to it so that you can look at that area and see this is artifact or this is real data. So I think, again, that's very helpful to have the patient's raw image right next to your topography as you're looking. So this is your screen. On the top of your topography, if you look at the very top of the image, it says axial/sagittal curvature. And so this is our axial map. And if we want to choose a different display, such as a tangential map or an elevation map or a refractive data map, we simply choose from that little drop-down menu our other choices, and it immediately switches to the other type of display. So this is our axial map. Again, I think we're all probably familiar with what an axial map is for topography. It gives us a general overview of the cornea. It gives us kind of refractive data. It doesn't really, it's not giving us a lot of well-defined or subtleties of the cornea itself. It's giving us a corneal overview from that perspective. A second type of display, again, from our dropdown, if you look now, it says tangential curvature. So here's our tangential map, which is probably the one that I use the most in clinic. It gives us, this is the exact same patient, by the way, just changed the display from the axial map we just looked at. And you can see the colors are more bright and more defined, and there's more color to the map because the tangential map is highlighting subtleties, it's accentuating the changes in curvature. So the astigmatism looks more stark in this picture than it did on the previous one. That's just the tangential formula, how it's calculated for any corneal topographer is going to give you this kind of look on a tangential map compared to the axial map. Again, everything on the left side is exactly the same as the axial map. The only thing that has changed now is our topographic display. Of course, we get an elevation map with a Placido disc topographer. We're not getting true elevation data, but we're getting a calculated elevation map. And you can see in this case what we've got, again, is a patient with some width of rule astigmatism and a ridge of elevated cornea stretching roughly from 3 to 9 o'clock. And this agrees with the astigmatic look that we noted in the axial and tangential maps. So you do have, again, this elevation map brought from the drop-down menu above your image. Everything else about the picture, again, is the same. And then finally, the other option you have in your drop-down is a refractive map. And the refractive map is giving us corneal power data. And so this looks a little bit different. And I personally don't use the refractive map a lot as a primary map, but we use it a lot in orthokerotology, and I'll talk to you about that in just a moment as we go through. It works great as a comparative map in managing ortho-K patients. So these are the 4 options for your topographic displays that you get in your base menu, just your display menu. And again, there's a whole litany of other types of ways we can look at the topography and data that will go through a little bit of that. We're only going to scratch the surface, but this is simply your topographic display. You have 4 maps that are built right in and easy to toggle between. Directing your attention to the bottom left side, beneath the photographic image of the patient's eye, you see a box there in yellow that's got a bunch of data. And we'll talk quickly about that data, which again is the same no matter how you choose to display your topographic map. There's a lot of important information in these boxes, some of which we use routinely, some of which we only use on certain patients. Obviously, the first thing that comes up in our far left columns is our corneal curvature, our keratometric values. So in this case, we've got K1 and K2 in diopters and in millimeters. So we have 864 or 39.1 by 792 or 42.6. We have our mean Ks both in millimeters and diopters as well. Next to that, we have a box where we are displaying the eccentricity of the corneal shape, both in the horizontal and vertical meridians. These eccentricity values are also in another display in the unit where it allows you to change the chord diameter of where we're looking at the differences in eccentricity. So if you really have a passion for understanding the corneal shape and how that affects success with corneal or with orthokeratology, again, you have a lot of ability to customize how you look at corneal eccentricity at a 3, 5, 7, 9, 11 millimeter chord, etc. The next box we see are axes of astigmatism. So in this case, 11.9 and 101.9. We have our amount of astigmatism for this patient, 3.5 diopters. And then moving over to the right, again, we have another box which is really useful, and that's this corneal diameter. Looks like the number symbol with cornea after it. In this case, says 12.01. We use corneal diameter a lot. Corneal diameter is, if anything, becoming a more utilized measurement for whether it's scleral lenses or ortho-K. Many ortho-K lenses now, the labs want corneal diameter information because they have a set diameter for the lens in mind, and it's, corneal diameter minus a millimeter or corneal diameter minus 0.6 of a millimeter. And so again, for that design to work optimally, they really want to know the corneal diameter. And that data is printed out immediately on your basic display with the keratograph. So again, just from an ortho-K perspective, for the beginning ortho-K practitioner, the important things, of course, are going to be our flat K or our K1 reading and our corneal diameter as far as getting the fit started. As we get more into ortho-K and understanding the finer points of it, we may delve into the eccentricity values a little bit more. So we're going to switch now to just how the keratograph can be used for orthokeratology. And again, we can go pretty deep on this. I'm not going to go real deep into it, but I want to show you just how we manage patients on all of our ortho-K fits. Again, I have more than one topographer, and I have a tomographer in my practice at the university, and we use the keratograph exclusively for all of our ortho-K fits and follow-up. So primarily, we're going to start by looking at a tangential map when we're determining whether a patient is a candidate for ortho-K or not. And then beyond that, we have some comparison maps that we can use. We have a compare 2 and a compare 3 map. And these are helpful, again, to see what's happening with treatment over time from one visit to the next or over a series of visits, again, which we'll go through that. And I'll show you some examples of how that's useful to know whether we're still making positive progress for a patient who's going through the ortho-K treatment process. So this is a map which you would use a lot, I would think, if you're doing ortho-K and using the keratograph. This is our compare 2 exam screen. And again, within the compare 2 exams, If you look at the map in the upper left, this is our pre-treatment corneal topography. It shows the eye, it shows the date, and within that drop-down menu above the image, you could switch it to any topography that patient has on file. The lower picture, exam B, shows you your map, that your afterwards map, so to speak, or your second map, and so that your difference map is subtracting the top one from the bottom, if you will. On the right, we see our difference map. And again, in this case, we're looking at a tangential map of a patient who's undergone Ortho-K treatment. And the reason we would use a tangential map for a patient with an Ortho-K treatment is to look at how well centered our treatment is, and also get an idea of how large is our visual axis that the patient's looking through, and how close in is that return zone of plus power. And again, from a myopia control standpoint, we'd like to keep the area of blue here relatively small, but very well centered. Again, on the upper part of the image on the right, the difference map, the B-A map, it says tangential curvature. If you prefer looking at it from an axial, elevation, or a refractive map, you can simply choose from that dropdown to switch to a different format, keeping the two comparison maps, and you can toggle between any two comparative views for that patient that you want, which is helpful because most of the time, what I want to look at is the tangential difference map, because that again tells me how well centered my treatment is. And I also want to look at the comparison refractive map, because that tells me how much refractive correction I've achieved for that individual. So here is that comparative map with the refractive. And what I love about this is, for our patients who are doing Ortho-K, we typically have the patient come back from the waiting room, and the very first thing we do is corneal topography. And so I'll have a student or a technician go do the corneal topography. They'll take the patient to the room, check their acuity, refract them if necessary, take a look with a slit lamp, and then come get me to come evaluate that patient. And my first stop is to the corneal topographer, so I can look at the patient's maps, because that's the all-important part of success with Ortho-K. More than looking at a lens on the eye, it's what does the topography look like after treatment. And based upon my comparative refractive map, I can see how much refractive error I've actually corrected. So if you look at this map, if you look at the image on the right, which shows you your difference refractive map, below that, you're going to see a graph with a curved line that dips in the middle. And if you look at that graph down the left-hand side of the graph, it's actually showing you in diopters how much correction you've achieved from before treatment to after. And in this case, it's telling us we've achieved something in the ballpark of 4.5 diopters of correction, 5 diopters of correction. So if I know that the patient pre-treatment was a -4.5, and I look at my refractive map of comparison and it says I've corrected 4.5 diopters, I can pretty well predict that the patient's going to be seeing 20/20 in the chair. If I don't have that much correction, I'm going to obviously see how much residual correction, residual refractive error they have. And again, I could almost predict before I even walk in the room how well that patient is seeing, what their visual acuity is, by using this refractive difference map. So again, this is extremely helpful to know whether we're over-correcting or under-correcting our patient as we are going through the process. We have a pre-treatment refractive error, and what we're shooting for is getting this refractive comparison map to level off at the bottom, right at the patient's pre-treatment refractive error. So another great feature is the Compare 3 exam option. And we use this also a lot. And the benefit of a Compare 3 from my perspective is it shows me the evolution of the fit over time. So in this case, for example, bottom left image is our pre-treatment map. The bottom center may be our 1 day or 1 week or whatever intermediate exam that I want to look at. And then the far right map will be the most current map typically. And so what you see is you see this patient's pretreatment, intermediate, and current topography. Then if you look up above, you're going to see the difference maps. And the upper left is difference between our initial treatment and our intermediate steps. So this was our first look at what the Ortho-K treatment was doing. And of course, what we see in the difference map is a dark blue spot in the center, which we expect. We have flattened the central cornea. We see a little ring of yellow around that. We've steepened the area outside the treatment zone, just like we'd expect. But what happens if we keep that patient in lenses and check again in a month, for example? Well, in this case, what happens is if you look at the upper right map, what's happened is that very centrally, the patient has not picked up any more correction. Maybe at the intermediate visit, they were already 20/20, no need for them to achieve any more correction. Our difference map from our intermediate visit to our current visit shows we haven't really achieved any more central visual correction. But as you move out from the very center of that map, you see it starting to turn blue. And what's happening is it's showing us that we've expanded the treatment zone. So we talk about Ortho-K, especially in adult patients. You know, we may say at first you may experience some nighttime vision issues, but the longer you do it, the better they get. Is that true or not? And I think what you find is when you do these comparison exams is you see that over time that even as you don't achieve any more central visual correction, sometimes if we stick with a treatment long enough, we do get a more complete and enlarged treatment zone, which does help patients with their nighttime vision, for example. So it's kind of fun to look at what happens over time. We have a lot of good initial central treatment, and then over time, we don't get any more central treatment necessarily, but we get more treatment just outside of that, expanding our treatment zone, and more of that plus power being developed as well, as we can see as that yellow ring is even brighter yellow and starting to orange. Just one last map that I think is helpful, and that is this Fourier map. And the reason that I like using this map on Ortho-K patients, it's a good troubleshooting map. And so what we see when we look at the picture on the left is we see the patient's corneal topography, and they've been undergoing treatment, let's say, for a month. And they come in for a follow-up, and they're complaining their vision's not that great. And they find their 20/30 or 20/40 vision, and you refract them, and you get a bit of minus power. And you look at the topography and think, well, that little spot of green that's extending up inferiorly doesn't look that significant. How significant really is this? Well, going to the Fourier map shows you, for example, in the upper right image and the bottom right image, that the decentration and irregularity values in this patient are actually quite high, and that we should expect that this little area of green is very visually significant. And so this patient, again, probably has a lens which does not have complete alignment inferiorly. It's probably riding high a little bit. It's allowing for an incomplete correction on the inferior part of the treatment zone. And that incomplete correction is leaving them myopic enough that it has a significant visual consequence. So again, this is a patient where just looking at the map on the left, you might say, I can't really tell whether, the patient just needs more correction or if this little island of green below is that significant. The Fourier display can bring that out and show you whether it is visually significant or not. Again, one of the other nice attributes of the Keratograph is the photographic capabilities. You can see here is just a photo of a patient's eye with an Ortho-K lens on. It's got built-in cobalt blue, built-in rat and filter enhancement capabilities. So you get very high quality fluorescein images of GP lenses on the cornea. So from a documentation perspective, if you like to document the patient's fit at any point in the process, whether it's pre-fit or through the process itself, the photography option's great to document those things for the patient's file. So I just have a couple cases I want to walk through now and again and just point out how I've used my Keratograph to monitor their care and how the treatment has evolved over time. This is a patient who I actually just saw yesterday back for his 6-month follow-up on his treatment. This is not a child. This is actually a 30-year-old graduate student here who, through his graduate program, continued to become more myopic each year, kind of a late bloomer, if you will, from a myopia perspective, and somebody who was concerned that his eyes kept getting worse every year, even though he's pushing 30 years old. One of our other clinicians at the school recommended he maybe consider Ortho-K as a myopia control, even though he's not a child, but just to control his myopia. And so we started with his right eye here. He was pre-treatment of minus 350, and this is his corneal topography. And it's not a wonderful looking map, probably one that I'd like to have back to do again, put artificial tear in and repeat it. But it gave us the data we needed to give us an initial lens fit. And so again, taking a photograph of the lens on the eye. And then what we'll often do is I like to have the patient put lenses on in the office when we get them in, either by ordering them or if we have them in our dispensing system. I like to have them sit in the exam room, tilt their chair back, close their eyes for a half hour or so if I can find a place in the office for them to hang out, and then take the lens off after about a half hour and repeat the topography. And the reason is it just kind of gives me reassurance that the lens is centering properly with the eyes shut and that the treatment is happening in the proper placement of the cornea before I send them home with them to wear overnight. So this is that same patient, same eye after 30 minutes of lens wear. You can see that we're starting to get some changes to the cornea shape in roughly the center of the cornea. So we have them come back, and just kind of skipping ahead here, I chose a map a few days in advance. This is now 3 days out on his treatment, and you can see that the area of treatment is relatively small, but it's taking good shape and it's properly centered, and we're making progress. Now his vision still isn't wonderful at this point, but he's patient, and we can reassure him by showing him these maps that it is happening in a proper fashion. We move ahead now to day 8. And again, the treatment is reasonably centered. The treatment is continuing to form into a proper shape where the corrected area is lying over the pupil, and we have our solid zone of plus outside of that. Now at this point at day 8, this patient is still not fully corrected. He's only 20/30. And so when we look at his comparative refractive map, what we see is that from pre-treatment to today, we're getting about 3 diopters of correction. And keeping in mind, he was a minus 350 to start with. So our difference map is predicting that we should probably still be a little bit undercorrected, and we are. Putting a little minus in front of him helps. But at the same time, we are making progress. And so when we do our compare 3 map, we can see that from day 3 to day 8, which is the upper right picture, there's still blue occurring in the center. What does that mean? It means that we're still getting more central correction. We have not maxed out our correction centrally. So we can expect that it's quite possible that if we just hang in there with the same lenses, that we will continue to get better vision. And indeed, this gentleman within another week or two was corrected up to 20/20 vision in this eye. So he would continue to get more correction as time went by. But again, our comparative map showing us from day 3 to day 8 that we're still getting central correction gave us reassurance to continue without necessarily having to reorder a lens that would be more correction at this point. So flipping over to the other eye, we see again, this eye is a little bit stronger, pre-treatment prescription a little bit higher. We've got a good starting point map here. Again, after 30 minutes of lens wear, we can start to see some changes occurring centrally. We're flattening out centrally, and we're satisfied that we can go ahead and dispense these lenses and see him back the next day. Again, skipping ahead a couple days, we go out to 3 days of treatment, and we can see again, centrally, we're getting a correction in the right place. The treatment looks pretty well centered over the pupil. And again, even though we're probably not up to full correction at this stage, we're satisfied that we're making progress. Moving ahead now to 8 days of treatment on this eye. Our treatment area is deeper starting to see some blue forming. We've got some greens there. If we actually look at the numbers, we're going to see that in our refractive data that we're getting up to the level that we need to be at for him to have proper distance correction. So again, we're satisfied, and we're going to go ahead and do our comparative maps then. So here is our comparative 2 map for refractive data. And again, if we look down at the graph on the bottom right, what we can see is that we are achieving, again, about 3.5 to 4 diopters of correction. And this eye at this point, again, was 20/20 correctable, or 20/20 uncorrected at this 8-day follow-up treatment. So again, the point of the maps for us is to make sure our treatment is properly positioned centrally with our tangential maps. And then again, what I like to do is know where I'm at with my refractive outcome. How much am I correcting? How much correction have I achieved through corneal flattening? And by having the refractive map do that math for me, I don't have to rely on my refraction, which, as we know with ortho-K patients, especially in children, can be somewhat inconclusive because of accommodation and the multifocal aspect of their cornea. So having the instrument measure this as an objective means of measuring a refractive outcome, for me, is very helpful. Again, here is our compare 3 map for this same individual on this left eye. You can see from visit 1 to 2, we've got lots of correction on our difference map. And even out to visit at 8 days, the upper right picture, we're still getting a little bit more correction even at day 8. And if anything, again, the correction's expanding, and the return zone of plus is moving further out. So we're getting a little bit more expansion of the correction as that as time goes by. So I have one other case just to kind of wrap up with, and then just a few parting comments, and we can take some questions. This was just another patient with that was undergoing correction ortho-K, and she actually had been in an ortho-K lens, and it wasn't working very well for her. So we washed her out and started with a different lens design, and this was her washed out topography, ready to restart again. And in this case, what we found was this is a 2-day post-treatment period. You can see a bit of a central island forming, and her vision was not that great, but the treatment was pretty well centered, and she was comfortable with things. So we continued on with the treatment. And then at 1 week, we can see that that island is dissipating. Our treatment zone is rounding out nicely. It's getting more defined and broader, and we're getting more central correction. At 1 month now, again, that treatment zone is expanded even further. We're getting full correction. The patient's vision now is 20/20 uncorrected in this eye using this treatment. And so again, what we can do is we can look at our comparative maps, and this map here is actually showing the same thing as our previous compare 3s, but it's this newer software that now gives us 3 maps across the top instead of just 2. But we can see what's happening is over time we're getting, again, more correction at each visit, a little bit more centrally and a little bit more outside of the central zone as that ring of treatment expands. By doing the comparative series, you really see, again, what's happening over time instead of just from one visit to the next. You can see the subtleties that occur not just from one visit to the next, but over time, the evolution of the patient's treatment. This is, again, the refractive or tangential maps for that same patient for the other eye, showing what's happening now between pre-treatment to 1 month and now a 3-year follow-up. And what we can see is from 1 month to 3 years, which is the central picture, very little change has occurred. The patient's prescription is stable, and we've got a very consistent topography for essentially a 3-year later evaluation. Here again is our refractive data, our refractive map. You can see in the upper left the significant flattening and significant amount of refractive correction from the pre-treatment to the 1 month. Now, 3 years later, the central map, we see very little color because everything is very stable. the prescription is not continuing to get, we don't get more correction over time. We're also not losing the correction we've got. We're at a very stable point and the patient continues to see well ongoing with the same lens design. So that's the keratograph instrument, again, on a very basic level, how we use it for ortho-K specifically. Our pre-treatment maps to look at the patient's eye, make sure their ocular or their corneal shape is regular, that they're a good candidate for ortho-K, and a baseline for comparison for future evaluations. We've also got the follow-up maps. We can do a compare 2, compare 3. We can see our treatment between one visit to the next. We can see the evolution of our treatment over time. And then we have several different ways of looking at our data without having to recapture. With just a single image, we can evaluate tangential curvature, refractive curvature, elevation data, our Fourier analysis. We can do, again, lots of other indices that are built into the instrument that you can use for comparison over time to evaluate how this treatment is working, whether it's doing what we want it to do. On a last note, there are a couple software programs out there that are very popular for orthokeratologists to use. So for people who want to be able to design their own lenses or have more control of their patient's ortho-K lens fit. And those two main programs are Wave and iSpace. And of course, the keratograph is fully integrated with both of these programs. The Wave software design, you simply capture your map in your keratograph, you launch the Wave application, and it immediately processes and designs your lens. And then once you know how to use the Wave software, you have full capability, again, to manipulate the lens design parameters within your Wave software. But pulling your data into the Wave program, again, it's literally a couple of seconds. Click a button, and immediately things open up and start to process. It's a very quick, very easy process. And the same with iSpace. We're going to open our iSpace software. We're going to pull in the topography we want to use, and then we're going to let iSpace do the work of lens design initially and give us the capability, if we want to manipulate the parameters once inside the software to fine-tune either the initial fit or in follow-up. So again, the keratograph is fully integrated with both these programs. If having a topographer that works with ortho-K lens design software is important, then again, the keratograph would meet all of those needs. So just to summarize, again, I think it's important to note how easy the keratograph is for patients and staff to use and to have it done on them. It's an efficient instrument. It's not intimidating. Just very easy to use. The quality of the maps is excellent. The side-by-side reference of the maps is a great aspect of it too. So you can analyze your map right next to your raw data image at the same time. Because your screen on the instrument, typically with the keratograph, we're working on a 21-inch monitor. There's lots of room. You can put a lot of information on that screen. Within one snapshot, you can look at everything you need to look at immediately and know whether this is a good map or not. The HVID measurement is very helpful. Again, it's just a built-in part of the display. If you want to, again, the instrument allows you the ability to use calipers, for example, to measure the corneal diameter. If you want to double check some aspect of it, you have measuring tools built into the device as well to measure anything you want to measure. Again, I love the compare modes to track changes over time. The photography is nice, it's helpful. Photography can also be nice too if you have patients who have maybe developed some corneal staining and you want to document it as you go through and manipulate your lens parameters to try to eliminate that problem. Having the ability to track those things over time is also quite nice, and the software integration is there as well. So that wraps things up from my side of things. I hope that you found this helpful. And again, just if you have any questions, obviously let Chris and the folks at OCULUS know, and they can get you more information. Thanks for your time.
Thank you, Dr. Jedlicka. I think there are a lot of good insights and case examples there. So I'll just remind everybody really quickly that you have a text box for questions on your GoToWebinar control panel, and if you type the questions in, I can give those to Dr. Jedlicka. And actually, we have a few questions right now. If you're ready, Dr. Jedlicka.
Yep, I am.
Okay. So the first question is, the Myers look a little off-center. Can we do an off-center measure to get geometric-centered map?
So you can manually override the capture capability. Okay. So if you have the desire to move the Myers around a bit and capture, you have that capability. So the instrument always starts off on auto capture, but if you want to have manual control, you simply can release the auto capture, I think, by hitting the space bar on the keyboard, and then immediately it goes into manual mode, and then you hit the enter key to capture your map. Now, clearly the rings on your topography are subject to the reflection off the apex of the cornea, things like that. But in terms of being able to move the Myers, the head of the topographer, around, a half a millimeter or whatever to capture your image, you do have that capability. You can do a manual capture.
Okay. Does the diff map do a standard scale, or does it optimize?
So yeah, I didn't even get into that, but if you look at any of the maps, the scale running down the right-hand side of your color map, you have, maybe you can talk about this too, Chris, but there's 4 or 5 different color scales you can choose from in terms of, like I prefer, I grew up with the old Tomei topographer years ago, so I like the TMS color scales, and so that's what I choose to use. But there are many other color scales if you had a topographer used in the past and you got used to a way of looking at the color maps. You can choose other formats for the color scales. Now, in addition to that, you can set the scale however you want. You have full control of the top and bottom end of the range. You have full control over the steps, the increments. You can do a fine, normal, or coarse evaluation. So you have complete control over how you want to visualize your maps. It's pretty simple too. At the bottom of your color scale down the right side, there's going to be a little box. And if you click on that box, it's going to open up all of the adjustable aspects of your scale, both in terms, again, of the increments, the colors, and the range that you choose. But it's going to choose a normalized scale to begin with, and then it's up to you if you want something different.
Yeah, no, I think that's perfect. I wouldn't really have anything to add to that. Okay. Yeah, you have the option of doing a more detailed relative scale if that's what you mean by optimize, and then you can have, if you're talking about standard scale as far as fixed incrementation and fixed colors, that's also another option. So yeah, it's very versatile as far as that goes. So the next question says, before a patient reaches full treatment, what do you give while vision is not quite fully corrected? Do you use daily soft contact lenses?
Yes. I guess that's not really part of our topic tonight, but absolutely. If I have a patient who's a fairly high prescription, again, it depends. If I have a 10-year-old child who came into the office and they were wearing year-old glasses, seeing 20/50, I'm not too worried about them seeing 20/50 the day after their first night in Ortho-K, and 20/30 2 or 3 days later. It's still better than they were. If I have an adult who's coming from glasses or soft lenses, who's used to seeing 20/20 sharp all the time, especially in higher prescriptions where I know that I'm not necessarily going to drive them to 20/20 from one night of wear, yeah, we'll usually do a couple pair of a daily disposable lens to to pop in if they feel like their vision's inadequate. Usually just give them something like a -1 or a 150. We let them know it's not perfect, but it may just kind of clean things up a little bit for them to function better if they feel like their vision's not acceptable for those first couple of days.
Okay. Next question, it's actually kind of 2 parts. Do you use the keratograph to decide on lens design and lens parameters, and what measurements from the keratograph are you using for that?
So that's a good question. I think that you know, I tend to use really 3 different lens designs routinely in the clinic, and without going into which ones they are, they're all somewhat different, which I think is important. One of them is a specific design, another one is a standard 4-curve, and then another one is a software integrated design. Again, I feel like if you want to practice full scope ortho-K, you want to have both, you know, a 5-curve, 4-curve, or 3-curve, 4-curve, and a software integrated design at your disposal, so you can cover the gambit. The typical mean for me is I have fitting sets in the office that I will use, and I will probably go to the same fitting set most of the time, unless there's a history there. And if that particular fitting set looks like it's not fitting properly, then I'll move to a different fitting set right away. Sometimes you can get clues, but my feeling is that it's less the cornea shape most of the time as it is the patient's lid tightness and tension and things like that that tends to drive a lens off center. So I like having a lens design that's got a narrower and a wider alignment zone, again, and then a software integrated design for when I need to go custom. What data do I need off of my keratograph? Again, if you're working with most lens designs now, for better or for worse, most ortho-K lens designs nowadays, the labs really want basic information, and they want control of designing the lens. They want the Ks, they want the RX, and they want your HVID perhaps. And they're going to tell you what lens, base curve, diameter, whatever, depth, sagittal depth of the lens you need. Over time, as you become better and better at ortho-K and you want more control of that process, then you start looking at other aspects of the fitting process. And some of the things that are important to note off of your map would be simply corneal astigmatism. If the patient has a certain amount of elevation difference in the mid-periphery of their cornea, that's going to dictate, you know, again, going to a toric design or a dual axis type design. So I think your map at the beginning stages of ortho-K, if you're sticking with patients who have relatively spherical prescriptions, you know, relatively straightforward prescriptions, the lab just needs the Ks and RX and the HVID. As you get better at it and you want to take on more challenging cases, which I think you should, because that's what makes life interesting, is tackling new frontiers on all the time. Take on that patient with more astigmatism, go to a toric design, or take on, you know, a patient with a higher prescription or more difficult lids to work with. Go with a design that allows you to have more control and challenge yourself and satisfy those patients. All the information is there, though, again, from the basic, I just need Ks and RX, to all the way up to doing a software integration where the entire map is custom fitted with a completely customized lens design.
Okay, so that actually does it for the questions I have here right now. If anybody has questions after tonight, you can reach us here at Oculus at the 1-800 number shown on the screen, or at sales@oculususa.com. If you missed part of the webinar, we will be emailing everybody that registered a copy of the recording, and then within a week or two we will have the recording also posted to our website, where you can find other recorded webinars, and that's at www.oculususa.com. We also have another website where we have recordings of podium presentations, and that's www.oculustv.com. So thank you again, Dr. Jedlicka, and thank everybody that was in attendance, and wish you all a good night.
Good night.